In Graves, we always blame the thyroid receptor antibody, but we today move beyond the binary game it plays, positive or negative, in the interpretation of Graves' serology to discuss the complex molecular immunology of TSH receptor. We often treat Graves' disease as a simple state of overstimulation. However, in reality, it's a dynamic immunological tug of war. The TSH receptor, which is a G protein coupled receptor that doesn't just sit waiting to be turned on. It is a site of competition for a heterogeneous family of antibodies that can stimulate it, that can block it, or even just bind and do nothing at all. So let's look at the core concept, the functional heterogeneity of TSH receptor antibody. It is an umbrella term. It refers to any antibody that has an affinity to bind to TSH receptor. Now we should distinguish between two primary functional subtypes. There are TSH stimulating immunoglobulins. These are primary drivers in Graves' hyperthyroidism. These antibodies bind to the extracellular domain of TSH receptor, specifically the leucine-rich domain, and induce a conformational change in it. This activates the cyclic AMP, leading to relentless thyroid hormone synthesis and follicular hypertrophy. The second is thyrotropin binding inhibitory immunoglobulins are there. This is where the nuance lies. Thyrotropin binding inhibitory immunoglobulins, or TBIA, is technically a description of a laboratory assay measuring the ability of the patient's serum to inhibit the binding of labeled TSH to the receptor. However, clinically we used to describe it as blocking antibodies. These antibodies bind to the receptor but do not trigger cyclic AMP cascade. Instead, they physically obstruct others, normal TSH and other TSH from binding and cause hypothyroidism effectively. Now, this is a switch phenomenon. Why Graves' disease flips to hypothyroidism from the usual hyperthyroid state? One of the most perplexing scenarios you will encounter in the clinic is a patient with biopsy-proven Graves who spontaneously become profoundly hypothyroid despite a normal size or even a uniformly enlarged small gland. This is the antibody switch. A patient's B cell clones can shift over time or under the influence of treatment from producing predominantly TSH stimulating antibodies to predominantly TBIA and produce hypothyroidism later on. Now, what are the factors influencing switch? Antithyroid treatment. Methimazole has mild immunomodulatory effect and may alter the balance of antibody clones. Radioiodine therapy. The massive release of thyroid antigens following radioiodine therapy can lead to a transient spike in all types of thyroid receptor antibody, sometimes altering the ratio of stimulating to blocking antibodies and may even result in predominance of blocking antibodies. Third is a natural history. The burnout of Graves can sometimes be an immunological transition rather than glandular destruction and no gland at all. So if your Graves patients become hypothyroid, but their TSH receptor antibody remains high, you are looking at the predominance of thyroid blocking antibodies rather than the end stage of the disease. Now, what is the laboratory implication of this? There are bioassays versus competitive assays. To manage these patients, you must understand that the lab is actually measuring competitive binding assay with a third generation thyroid receptor antibody. They measure the total ability of the antibodies to compete with the TSH for the receptor. They cannot distinguish between stimulating antibody and a blocking antibody. They tell you the crowd, but not the character of the crowd, but not whether they are starting a party or locking the building. Cell-based immunoassays are there, which are TSI specific. These measure the actual production of cyclic AMP in the cell line. This is a functional assay. If the TSI is high, you have stimulation. Now coming to the last part of it, pregnancy, which is a high-stake, no-negotiable situation. This is perhaps the most critical application of TSH receptor antibody nuance. You will often be asked to consult a pregnant woman with a history of Graves who is now euthyroid after a total thyroidectomy or radioiodine. Now the trap is that most of us think that she has no thyroid, so there is no risk of thyrotoxicosis. In reality, the mother has no thyroid, but she still has B cell clones, and transplacental transfer of IgG antibody can easily happen. Both receptor stimulating, TSH receptor stimulating and inhibiting can freely cross the placenta, particularly in the third trimester. So if the mother has high TSI titers, the fetus, in fact, thyroid gland will be relentlessly stimulated and fetal or neonatal thyrotoxicosis can happen. The child born with tachycardia, goiter, advanced bone age and heart failure. If the mother has high thyroid inhibiting, blocking titers, the baby will be born with transient neonatal hypothyroidism. So the third trimester rule, as per the guidelines of ATA and AAC, is that mandatory measuring of TSH receptor antibody at the end of 20 to 24 weeks, and in all women with active Graves' disease, all women with a history of Graves' disease treated with surgery or radioiodine. The threshold is that a TSH receptor antibody titer of more than 3 times the upper limit of normal is a massive red flag. It predicts neonatal thyrotoxicosis with high sensitivity, requiring intensive fetal monitoring via ultrasound to look for goiter and heart rate, and a specialized pediatric team for delivery. Now, there is also a mixed state of Graves' orbitopathy. We must also briefly mention that Graves' orbitopathy, the TSH receptor is expressing on the orbital fibroblast as well. In the orbit, both stimulating and blocking play a role in inflammation and adipogenesis. High total receptor antibody are a strong predictor of severity of progression to orbitopathy, even if the thyroid is removed. The tug of war is that the orbit continues to, as long as the antibody remain responsive to that. This is why so aggressive about smoking cessation and avoiding radioiodine in patients with Graves' orbitopathy. To summarize, as you move into practice, remember that the TSH receptor is a contested territory. Don't just look at TSH T4. If the clinical picture doesn't match the labs, that is, a patient has a goiter who has hypothyroid and has a TSH receptor antibody, think about thyroid inhibiting blocking antibodies, TSH blocking TSH receptor antibodies. And pregnancy it's all about the baby's thyroid, not the mother. Euthyroid mother can still have toxic levels of TSH in receptor antibodies for the fetus. Next thing is, patient can migrate from one side of the spectrum to other. Understand the nuances of TSH receptor antibody allows you to predict the unpredictable paradoxical flip from hyperthyroidism to hypothyroidism, or a hidden risk to a developing fetus.